is a title that I thought up uh, a while ago for speaking to a general audience, a public audience that had a lot of students in it, and I thought this was sort of a fun title about how hard it is to count. And it seems like a simple problem, right? The way that you count to 60 million is just to keep going and not stop until you get there. Um, but really, the challenge in numbers like this comes from, well, what it is you're actually counting. And this number here, 60 million, which was in fact was 57 million the first time I wrote this, and was 54 million the year before that, is our estimate of the number of childhood deaths that have been uh, avoided by measles vaccination globally since 2000. And every year we update this number. And it's a challenging number because it requires counting a thing that didn't happen. These are deaths that didn't occur. And the way to do this is the only way to do this is to make models. One is a model to help us understand the number of measles deaths that did occur. And again, this in and of itself is a challenging thing. Most of those infections and then deaths occur in the community. They're not recorded in health systems, so they can't be counted directly by pointing your finger and touching each one. Um, uh, so that necessarily requires the integration of data and models to come up with an answer that is defensible, right? And then to get even to get the full number, right? How many deaths were averted? We need models to do something even more so, right? Which is to count what would have happened in the absence of this vaccination. Um, and I'll talk in a minute about some of the approaches the general story of the approaches that we've taken to do this, right? But again, a question, how to count to 60 million, that sounds simple enough, right? The way you do it is you don't stop counting. But in a specific context is a much more challenging question that underlies a lot of I think the complexity of both the development of mathematical models, the integration of public health data, and the communication of that to both policy and the broader public community. Um, all right. And so I'm just going to give a little bit of sort of background and motivation. Again, some of this is targeted towards a broad audience because I wasn't sure what the breadth of backgrounds here, how many medical doctors there are versus mathematicians, and so I always like to sort of start things off um, fairly simply. But so for me, the beauty in the natural world that I've spent the last 2 decades chasing is the nonlinear dynamics of immunity to infectious diseases, and I'll be specific about what I mean when I say nonlinear here. And so, it's fascinating to me that the interactions that we can see among molecules in each of our bodies, antibodies and viruses, can generate these highly structured and really predictable patterns that exist and are predictable and can be forecast over the scale of decades and over continents. Um, so to start, the first pathogen that I'll talk about here is measles. It's a viral disease. It's a concern worldwide, and unfortunately, I don't need to remind anyone in either of our two countries of the concern of measles. Measles is a meaningful source of childhood mortality in Nigeria, and though in the United States we haven't had childhood deaths for many years, we have had 3 deaths, two in children, one in an adult this year. So even though the US has officially eliminated measles, which means that we haven't had 12 months of continuous transmission, we've seen an increasing number of outbreaks and increasingly large outbreaks year on year. Right? So this is an enormously transmissible virus. It can lead to quite severe outcomes in young children, secondary infections, disruption of immune response, that allows opportunistic infections. And in under-resourced areas where those infections can't be well managed, it can result in mortality of 1 to 5% of children who become infected. And so, despite enormous efforts to vaccinate children around the world, and in fact, enormous success in reducing the number of childhood deaths annually, measles still results in 130,000 deaths, give or take, in children under 5 every year. And this is a much smaller number than when I first started counting, in large part because we have an enormously safe and effective vaccine that prevents both infection and spread. Um, but again, this remains a important topic for humanity and a fascinating intellectual topic that has motivated me for many years. So first, when I say nonlinear here, I mean that the change in a dynamical system is not directly proportional to the change in the input. That's the definition of nonlinear that I use, and in particular, it depends on the current state of the system. So a 10% increase in measles cases when they're rare is very different than a 10% change in cases when they're common. And the way this manifests in immunity, individuals being immune, is that the per capita risk, assuming that you're susceptible, drops by a larger amount with each additional immune individual. So each additional immune individual in the population increasingly reduces the risk for everybody else. Right? And here I'm not making any distinction between immunity due to infection or to vaccination. The latter is clearly the better option because it doesn't come with disease, but from a mathematical and dynamical standpoint, those two things are functionally equivalent. And this is summarized in the easily caricatured and often misstated phenomenon that is called herd immunity or shield immunity, where having one immune person in your contact sphere reduces your risk by a small amount, and having 5 immune people in your contact sphere reduces your risk by more than 5 times. And somewhere before 100% of people are immune, your risk drops to functional zero. And that the change in the amount of that risk reduction as you increase the number of immune people around you, that is the nonlinear response. And those phenomena are summed up mathematically in this wonderfully elegant system of equations called the SIR model that some of you, I'm sure, are very familiar with. Um, and this is the class of mathematical models stated here in ordinary differential equation form that I've spent 20 years working on. And versions that are as simple as what's on the screen right now and much more complicated versions to match these to individual systems. And in particular, what the phenomena that these models formalize is that when immunity is low, transmission rates are quite high and infection increases rapidly. Um, and then when immunity is high, those transmission rates are low and infection decreases. And it creates this undulating system of increases and decreases in prevalence um, and um, uh, and and corresponding outbreaks. So I've worked on the math of this, adding complexity to this very simple mathematical skeleton, and then developing abstractions of the very complex models to simplify them and then match them to observed data, and working on then the statistics of trying to estimate the specific rates and the specific values of the rates inherent in the Greek symbols that are shown here, and the variation in those things across space and time, and then what that means for the resulting epidemiology and control of this pathogen. Um, while those cycles are predictable, their characteristics in any given place depend on the birth rate and the interactions with the regular cycles of human behavior that affect the aggregation of susceptible people. Uh, and so, in some parts of the world, indicated with the time series here in England, very famously, these cycles align with things like school terms that bring susceptible kids together, and that generates the timing of when these outbreaks tend to occur. In other parts of the world, um, uh, uh, work that I did many years ago, focused in Niger with the Ministry of Health there. We find that these cycles and these high points in transmission align with agricultural cycles that bring to get people together after the harvest. Um, and then in small towns and in sparse populations, individual outbreaks can reach most of a small number of susceptible people, leading to local dynamics of extinction, and that which then allows the buildup of susceptibility through births, and then sets the stage for subsequent explosive outbreaks. And so this gives a sort of beautiful array of variability and cycles that we see around the world. And despite the fact that I said the word beautiful about a pathogen as severe and harmful as measles. And again, I find the biology and nonlinear dynamics of measles fascinating and wonderful, and it has been the source of enormous development in the field of mathematical biology and mathematical epidemiology. The fact still remains that this is a pathogen that causes over 130,000 deaths in children every year. And so that's more than 300 children dying every day. Um, so we can look, and I have spent my professional career looking at this pathogen and the mathematics surrounding it from two lenses, right? One, from the perspective of a mathematical biologist who is fascinated and excited about the patterns that we see in the world, and the other from a humanitarian perspective. Um, and so trying to understand in a world where we have vaccines, how we can um, use and measure the impact of vaccines and the impact of vaccines upon these dynamics, and then uh, implement them in models to help us design vaccination programs to control and eliminate measles and a number of other vaccine preventable diseases. And I'll talk about rubella here in a little bit. And so measles and rubella, which we'll get to, these vaccines are fantastic. They're enormously safe and effective. Um, we can talk about the specific characteristics of the vaccines later if you like, but for the moment, I think it's sufficient to say these are enormously effective vaccines that both prevent transmission and disease. Um, um, and in most of the world where I have focused my attention, we're talking about either the measles only or the combination of measles and rubella vaccines. Um, but what we've seen globally, right, these vaccines have been around for over 50 years. What we've seen globally is that um, vaccines aren't enough. Vaccination, which is our effectiveness at getting these vaccines into children, is largely the more important issue, and it's trying to understand the dynamics of vaccination and representing vaccination programs into these dynamical models. That is critical to understanding why measles persists and how we can update, improve, and develop vaccination programs to achieve goals of control and elimination. So for both measles and rubella, we use three kinds of vaccination globally, and they fall into these three buckets. And right now, I'll refer to these in the context of measles, but I'll switch to measles and rubella combination vaccines in the second half of the presentation. So routine immunization is the most common globally. These are well child visits that require parents, disproportionately mothers, to bring children into clinic at specific target ages for a first and a second dose. And in places where measles is endemic, these doses are given earlier in life because the vaccine is more effective in younger children. Um, and the severity of the disease is higher in younger children, and so we target younger kids particularly. In lots of poor countries, it's hard to reach this high coverage with routine vaccination alone, and there's enormous disparities in the accessibility of routine vaccination across across all countries with high and low access areas. Um, this is again, this is the a large part of the reason for this variability is a limitation of access itself. The vaccine has to be kept cold, so facilities in remote areas usually can't vaccinate, um, and it's a long and expensive trek for parents to bring their kids in on schedule. So sometimes we have strategies called supplemental immunization activities that bring those vaccines out into communities. These address the access issue by bringing vaccine to the people, but they're heavy and they're expensive. And so we usually only do these every several years, leaving periods of increasing outbreak risk in between. So not only is vaccination low in the periods between these activities, the population of susceptible children, that is the fuel that drives epidemics, is increasing over that time. So risk is accumulating. And then finally, when outbreaks do happen, we often deploy smaller and lighter targeted reactive vaccination campaigns or outbreak response um, that are like SIAs, but in order to be fast and targeted, they're necessarily oftentimes inefficient and can't address the full breadth of the population. And so the goal overall in the development of vaccination programs is to get to a world where we only have to do this first activity. We only have to do these routine immunizations. We don't have to do the heavy and expensive periodic supplemental vaccinations. And then because we have eliminated it, there are no outbreaks, and so we never have to do the outbreak response. And so again, 60 million is the number of measles deaths that we have estimated to have been averted by vaccination since the year 2000. Um, and how do we get to that number? Well, as I mentioned before, right, to get to deaths averted, you need two things. You need the number of deaths that did occur, right? An estimate that can in principle be predicated on observable data, and the number of deaths that might have occurred in the absence of those vaccination programs. And neither of these is very easy to estimate, but they are at least strongly related. And they're related through these mathematical models. So one of the first independent projects that I took on over a decade and a half ago was to develop statistical methods for the World Health Organization to estimate the total burden of measles infection and mortality worldwide. And so before that, measles burden was estimated using a demographic model that multiplied the number of births in a country by the proportion unvaccinated and assumed that a fixed fraction that was the same in all countries and in all years became infected. And so now as coverage increased, this sort of simple algebraic formulation that didn't have those strong nonlinearities in it meant that cases and deaths necessarily had to decline as coverage increased. And this meant that the estimated burden that was coming out of WHO HQ in Geneva didn't necessarily track with the year-to-year fluctuations due to outbreaks that many countries were seeing and were seeing in their clinic-based surveillance system. And so this led to a challenge and a conflict in the interpretation of this. And the problem with using clinic-based surveillance is that only a small and unknown fraction of the community has access to health services in the first place and then gets recorded as a case in the clinic. So we need to estimate that reporting fraction independently, and it'll be different from country to country as a function of the accessibility of their health system. And so at the time, I was working on a class of statistical methodology that comes out of signal processing and engineering called state space models or hidden Markov models. And those are a class of mathematical and statistical models that specifically take a dynamical process that can be represented by that SIR model that progresses in time and therefore creates correlation in the observations through time that are linked through the nonlinear processes that are represented in those equations. Um, and uh, and uses that to estimate the trend, and then looks at the difference between the trend and the distribution of differences between observation and model's trend to estimate the underreporting and therefore reconstruct the unobserved incidence of infection. So we published this methodology with the World Health Organization in 2012, and it was at that point adopted as the standard protocol for the World Health Organization, because we linked surveillance with an underlying model of how cases now lead to cases in the future. We also then got estimates of transmission rates and the values that go into these SIR models. So we got a dynamic model of measles transmission that was then fitted to each country and specific to each country in the world. And this allowed us to then generate simulations from the model of what the world would look like without vaccination. So the figure that's shown here on the screen, the bottom of this figure indicates our estimate of the number of measles deaths that had occurred. And then we took that model and removed the vaccination component of it, and we're able to project the upper value of this to get an estimate of how many measles might have occurred in the absence of vaccination. And then we could take the summed area between those two curves to come up with an estimate of the total number of measles deaths that were averted at the time. Right. Um, and so this now gave us a mechanism now for simulating not just this one scenario in the absence of vaccination, but many, many scenarios with different kinds of vaccination implemented to look at now the relative benefits of different approaches to vaccination. And then importantly, we did this again in 2013 and got slightly different estimates. We had another year's worth of data. We refit the past, and that not only updated our estimate of 2013, but it changed our observation of everything in the past. As we add data to the data set, it gives us not just changes our perspective of the present, but it also changes our perspective of how we got there. So we did this again and again. And when we fit the model again, we don't just update the estimate of now, we refit all of our estimates into the past. And this was a really powerful conceptual challenge for policy, but it should make good scientific sense. Every year we get more data, more observations of how reported measles cases change as populations grow and as vaccination changes. And so that's more information with which we can interpret where we came from in the past. So our perception, our estimate of the past and the rates should change as time progresses. And again, that we've done this over and over and over again until present. I'm in the process of doing this now with the World Health Organization for this year. And as time has gone on, we've refined the model. We have longer and longer time series, which means more and more data that allows us to actually change and fit more complicated versions of the model. So the version of that we fit now actually has additional components that we did not have enough data and enough observation to fit in the past. And so over time, as time has gone on, the uncertainty in our estimates has gotten smaller as well. So the bounds on this uncertainty has changed over time. And what you'll see here as I switch from the last slide to the estimates just in the last few years is an important change, right? Now the top line, the number of deaths in the absence of vaccination is now going down. Before it was increasing, right? And this is because of work that was done that I'll mention here again in a second by Alison Portnoy and Alyssa Spara to estimate the temporal trend in measles case fatality ratios. And early on, we had assumed that the case fatality associated with measles was constant over time. But their work showed that in fact it has been dropping over time, and it took years of work to estimate that. And so we could only incorporate that over time. But that not, again, it's a strong illustration of how the contemporary work not only changes our perception of what's happening right now, but it gives a change to our perception of everything that has happened in the past. Right. So over the course of this, we've seen dramatic reductions in measles mortality since 2000. And this mortality reduction has been driven in large part due to fewer cases because of vaccination. Vaccination has increased dramatically over this time. But also what we've seen here is a shift in the age of cases to older kids. And this is something that we're going to spend most of the next half hour talking about. But a natural prediction is that as a virus becomes rare, it takes longer on average for a child to encounter it. And so that infection tends to occur in older age children as disease prevalence becomes rarer. That doesn't mean that young children don't become infected, right? And in fact, the distribution or the age distribution of infection may still have a mode in the youngest of children. But more and more children make it to older age without having experienced this. And so the mean gets pulled up. Um, and so, so that shift towards older cases as prevalence declines, right? And again, as I said, this is a critical point that I'll return to again here, more importantly, because it's a key component of the rubella story. Um, and so, as I mentioned, then we took that phenomena that was observed within both the empirical data and in model simulation, and combined that with the estimates that came out of this wonderful work that was done by Alison Portnoy and Alyssa Spara, showing that two really critical phenomena were occurring, right? One was that the measles case fatality rate, the number of children dying per case, decreases with age. It's more severe outcomes in younger children than in older children, and that's a very steep decline. So shifting the mean age of infection because of vaccination necessarily means that the kids that are becoming infected are less likely to die, right? Um, so first, the measles CFR decreases with age, and the mean age of cases has increased with vaccination. But also, what they've shown is that the measles CFR overall across all ages has decreased with health system development globally, and that decrease has been variable from country to country. And so, combining all of those things, we actually get a strong interaction where vaccination reduces the number of cases, the reduction in the number of cases and the reduction in prevalence increases the mean age of infection. The mean age, higher mean age of infection is now correlated with a lower case fatality rate. So we get a positive feedback that gives rise to increasingly lower mortality over time. So we get a double benefit of vaccination, not only preventing infection, but shifting infection into lower risk age categories. And so we get an additional, so we get nonlinearity in the dynamics of transmission, but then also a nonlinearity that occurs in the dynamics of mortality associated with measles. But of course, critically, what we found here is that this reduction in measles cases and measles mortality hasn't been equitable, and there are places where measles still persists. And those are also those places where measles persist are also the places with the highest risk of mortality. And so, of course, this just reinforces the insight that while large vaccination investments were initially enormously helpful in reducing measles cases, we're at a point where we need more and more creative approaches to reach um, uh, the unvaccinated children. Um, so that's to bring to an end the first half of this, right? The discussion about measles and this powerful positive reinforcement that we got between vaccination age and reduction in risk and reduction in severity of infection because of a shift to older infection. But now what I want to do is I want to shift and tell a story about rubella virus and some of the challenges that we've come. So rubella virus has classically been used as a cautionary tale about the complexity of um, counterintuitive consequences of vaccination and some of the dangers of predicting the future. And my work over the last several years has been trying to rewrite some of that story. It still remains a cautionary tale, but I think it is now a cautionary tale about the challenges of updating our understanding and translating that understanding um, into public health practice. And so, predicting the future is a dangerous business. but it is sometimes a necessary evil. And I've spent, again, much of the last year and a half working very intensely with a variety of partners um, on the case for the introduction of rubella vaccination into the last remaining 19 countries in the world to do so. And that number has changed depending on how we count this. That number is now some closer to 11 because there's been a lot of activity. Um, when we started in 2024, there were 19 countries that had yet to introduce rubella vaccination. Now, many of those countries are in the process, or either in the process of rolling out rubella vaccination, or in the process of planning their introduction. And it might sound like quite an easy sell to introduce vaccination, but the dynamics of the system and the dynamics of the epidemiology make that not quite so obvious. And dynamic models here were really critical to help us anticipate what the future that might come to pass, and try and develop strategies to mitigate any potential bad outcomes that may occur, and to target surveillance to tell us whether or not we're heading down the wrong road. So again, normally we think that as vaccination increases, the incidence of infection declines, which is the point. But as I said before, the mean age of infection also goes up when that happens. And as in the story for measles, that's fantastic, because that means that because older kids are less likely to have severe outcomes. But for rubella virus, that can result in significant challenges. Rubella is again another directly transmitted virus, has similar presentation to measles. It's much milder and much lower risk of severe outcomes. But the challenge is that 60% of infections that occur during the first trimester of pregnancy can lead to very severe complications called congenital rubella syndrome, or CRS, as I'll refer to it throughout the rest of this. And CRS can manifest as loss of the fetus, and those children that are born may suffer from deafness, blindness, congenital heart disease, intellectual impairments. And in under-resourced settings where um, there isn't the support for these children, very few of these children live past early childhood. So again, while infection for most people is comparatively mild, infection in this critical demographic of women in the early stages of their pregnancy can lead to these really quite severe outcomes. And unfortunately, CRS is enormously hard to document clinically, because it requires that one of these outcomes of CRS occurs, which can have many other causes as well. And you have to then do a little bit of historical epidemiology and provide evidence that the mother was infected during her pregnancy. So this is an enormously complicated process to document and provide empirical evidence for. But the current estimates are now that CRS affects about 30,000 pregnancies and 30,000 families every year. Most of the world vaccinates for rubella using a combined MR or MMR vaccine. But at the start of 2024, 19 countries did not. And the reason was that 18 of them couldn't afford to do so on their own. And all of them would have been violating World Health Organization guidance to do so. And I'm going to walk through the logic of that and talk about the guidance and the work that we've done to change that guidance. Um, and I should note that Nigeria is on the list there, highlighted as one of the countries that had at the beginning of this process not yet introduced rubella vaccination. But Nigeria is one of the countries that is in the process of rolling out rubella vaccination now, in some part as a result of the changes to some of these policies. And again, the reason for this is because of a paradox that I've already alluded to, but I'm going to make more explicit now. So in the absence of vaccination, where transmission rates are high, then most people are infected early in life, and therefore most people immunity here indicated by the amount of pink in the figure. Um, most people are immune by the time they reach reproductive age, and so the risk of complications and CRS by getting rubella during pregnancy is enormously low. Right? But if transmission rates are low, then immunity accumulates more slowly, the mean age of infection is higher, and more people may reach reproductive age without being exposed, which then leaves those remaining pregnancies, the extra bit shown in blue here, potentially at risk for CRS. And so vaccination increases the overall immunity, and specifically more people are immunized at earlier ages, but it also can reduces the amount of circulating virus. So the immunity among those that are unimmunized accumulates more slowly, and that can manifest in this paradox where if you vaccinate at a high rate and lots of people are immune and there's very little circulating virus and the risk to pregnancy is low, but if you fail to reach that high rate, then there will be many non-vaccinated individuals and less circulating virus. So you can actually result in an increase in the number of pregnancies at risk. And this is the paradoxical outcome that has structured WHO policy prior to 2024. And it hinges on this definition of what vaccination level is high enough to prevent this risk from happening, right? And the underlying process that generates this is the nonlinear feedback between vaccination reducing risk of transmission and therefore shifting the age distribution of infection. And so the understanding of this began with a wonderful paper in 1981 by Elizabeth Knox that characterized this, what was called the paradoxical effect of rubella vaccine introduction. This first paper illustrated this initial transient decline in rubella prevalence and the potential increase for future incidence of CRS above a pre-vaccination baseline if routine coverage was sufficiently low. Paper by Anderson and May then developed this for the explicit case of the introduction of RCV rubella-containing vaccine for England, and estimated a critical threshold of 55%, which that was their estimate of high enough. And if you're above 55%, then the risk is low enough, and if you're below 55%, then you're in this sort of danger zone. All of this work was done in the context of routine vaccination only, not accounting for the supplementary campaigns that are now commonplace for measles and rubella control in endemic countries. Several countries then estimated the transmission rate or R naught for rubella to be between 6 and 12 based on age-specific serology or the age of infection. Most of those studies were done in Europe. But there were two studies from the Gambia and Ethiopia that gave much higher numbers. And those drove for many years the assumptions about transmission rates in low-income countries. Remember, the dynamics suggest that if transmission rate is high, then you're in this upper scenario. And so the perception at the time was, because of these two studies that were done in the Gambia and Ethiopia, that all of Africa was in this former category and was at comparatively low risk, and so therefore deprioritized for introduction of vaccination. Between 1999 and 2007, there were case studies from Greece and Costa Rica, which were published that gave evidence suggesting that the paradoxical effect of rubella introduction could occur. And these countries saw 10 years after their introduction, they saw rubella outbreaks that had large increases, that had increases in CRS. But again, note that these countries used routine immunization only and had none of the campaigns. These were observations that were consistent with the paradox, but because they did outbreak response vaccination in response to these, it wasn't clear whether or not the true new equilibrium setting would in fact have led to higher CRS than at pre-vaccination baseline. But this was the cause of great concern, and again, then structured much of vaccination policy following on from that. In 2000, the first rubella position paper cited 80% as the high enough, and this was an expert sort of an expert elicitation decision that 80% was the critical threshold, and below 80%, if countries couldn't reach 80% vaccination coverage with their routine program, then it was considered too risky to introduce rubella vaccination, and over that would have been safe. This guidance was updated in 2012 to include some consideration of campaign coverage. So again, now adjusting to the operational reality of the strategies the countries were using on the ground. and increasing the number of eligible countries. Some research that was published in 2012 by Jess Metcalf and others highlighted the interdependence of both transmission rate and birth rate. So now interactions now with demography in determining the critical threshold. And that was the first paper that indicated that 80% was in fact likely to be highly conservative for all but the highest transmission and birth rate settings. Um, and then work by Lessler and Metcalf thereafter illustrated that even despite that, that introduction of periodic SIAs could also prevent that paradoxical increase, even at low routine immunization levels. The WHO updated their petition paper again in 2020, still holding with the 80% rule, and then in 2022, a new comprehensive analysis of rubella transmission rates estimates were published. This was work that was done by Timos Papadopoulos and Emilia Vinicky, which showed that in almost every study they could find across years and years and years, the transmission rate was much lower than the level that would have required an 80% threshold for the paradoxical increase in rubella. And in fact, that in African and Middle Eastern countries, which were disproportionately the countries that had yet to introduce RCV, the transmission rates there were not systematically higher than anywhere else. And so recall the earlier work had suggested that that Africa was in this top setting, when in fact the updated estimates from more recent analyses suggest that in fact most of Africa was more likely to be in this relatively lower transmission setting, which would have implied that even in the absence of vaccination, there may be a large number of women making it to reproductive age. And still susceptible to rubella. And so work that I participated in and with many others specifically addressed the time scale of this paradoxical effect. And this was, again, really critical in that most of the work up to this point and most of the story that had developed based on what I've told you thus far was predicated on the equilibrium solutions to these dynamical system equations. But in fact, that what's critically important here are the transient dynamics right after infection. So if we think of this in terms of the equilibrium incidence of CRS, which is indicated here as this dashed green line, this is the function of the transmission rate, the corresponding age distribution of infection, and the age-specific birth rate. In the absence of vaccination, that CRS risk is expected to be highest in places with low transmission and lower birth rates, because low transmission means that many people will make it to childbearing age without exposure and therefore having babies later. And in high transmission and high birth rate places, that means that most people are infected as children and protected by immunity at reproductive age. I know I've said that 3 or 4 times now, but it's a critical component, so I make sure to repeat it. But then when we introduce vaccination, indicated here in the schematic by the yellow line, right, what we always see is an initial transient decline in both rubella and CRS incidence. And that corresponds to the slower cumulative increase and the difference between the no vaccination and the vaccination scenarios gives the net benefit in terms of the reduction or in terms of the CRS cases avoided. Again, this is now counting the cases that didn't occur. And this initial case is a robust prediction of all models, that we get an initial transient decline before return to whatever the new post-introduction equilibrium is. We then expect this post-introduction rebound in CRS incidence after a period that's referred to as the honeymoon period, and that stabilizes at a new equilibrium annual incidence. And the demographic rates. So sorry, if vaccination is high enough, then that equilibrium incidence will be lower for the no vaccination scenario, and the cumulative incidence is always lower. If the cumulative incidence is always lower, then you always get positive net benefit. But the concern, right, is if the post-introduction equilibrium incidence of CRS is higher than the no vaccination baseline, then we get this thing called a paradoxical effect. But notice that paradoxical effect only occurs after a period of time, and it only occurs after a period of many years. And so that assumes a static vaccination program between now and when that future phenomenon may occur. And it's important to note that this paradox doesn't manifest immediately. and projections using current demographic and transmission rates for the remaining countries to introduce indicate that equilibrium will not be reached for more than 10 years. And so that implies that there's in fact time to benefit from the transient reduction in the short term, as well as improving vaccination programs between now and 10 years from now to avoid that downstream increase and paradoxical effect. Um, and so, so while there are settings where it is possible um, that the equilibrium increase will in fact be high enough that there will be net harm in the long term, right? Those become now the situations that we need to address, and we can target those to design vaccination programs and monitoring programs to evaluate whether or not we're in that situation and what the strategies are to mitigate that. So while the theory of all this was robust and well supported, the actual coverage threshold to prevent that future paradox was highly dependent on the specific epidemiology and demography of each individual country. And so using a one size fits all threshold is likely to miss individual countries. And so our empirical understanding has been progressing over time, just as with the story of measles. We're learning more as time goes on. We're getting better estimates, and we're getting in a better place where we can tie down what these critical thresholds are for each individual country. Um, and we can absolutely improve our understanding of where we are since the first analyses of these were done in the 1980s. Um, and so the new evidence that has emerged through work that has been done across a variety of countries is that transmission rates are in fact lower than expected. And I showed you the results of the work that was done by Timos and Amelia earlier, indicating that there's likely to be comparatively high risk and high burden of CRS in the moment in the absence of vaccination. And this work included two large-scale national studies that were done in Nigeria and in DR Congo. And these two countries account for a huge fraction of the estimated CRS burden globally. And they're large enough to reflect the broad diversity of rural to urban and low to high access settings. And so the analyses done in these countries were really powerful in making the case to World Health Organization for the reevaluation of these strategies. And so I'll quickly mention and show some figures from the work that was done in Nigeria. So at the time, Nigeria still has yet to fully introduce rubella vaccination, but is in the process of planning and implementing rubella introduction. Notably, Nigeria is enormously diverse, has strong gradients from south to north. Measles vaccination coverage, which is the assumption of what rubella vaccination coverage would be in the future, is quite high in the south and much, much lower in the north. So there are parts of the country that are above the introduction threshold, and there are parts of the country that are below the introduction threshold. So this gave an opportunity to look across this gradient in a single setting, with consistently collected data. And this is a project that we did in collaboration with the Nigeria CDC and the US CDC to analyze a large nationally representative serological survey to understand the current distribution of risk for rubella and how that might change when measles-only vaccine is replaced with measles and rubella combined vaccine. And so in a bunch of work that was conducted by Tenley Brownwright here at Penn State and Taishi Nakaze, who was at Princeton at the time, has shown that the transmission rates for rubella are about 2 times higher in the north than in the south. And this was predicated on developing a mathematical representation of the pattern that's illustrated here on the screen. And so each facet in each box here has a line that represents one state in Nigeria, and the boxes are roughly aligned geographically, with the top being northern states and the bottom being southern states. The x-axis in each facet is age in years, and the y-axis in each facet is the proportion of individuals of that age that are seropositive. And so this is derived from a large national serosurvey of over 135,000 participants across all ages between 6 months of age and 45 years of age. Um, And what we see here, right, is that in the southern states, the rise in the proportion of individuals seropositive is comparatively slow. And in the northern states, that rises rather quickly. And it's very high in youngest children in the north and comparatively low in the youngest children in the south. And because Nigeria has not yet fully introduced rubella vaccination at the national scale, this is largely a reflection of the transmission of rubella virus in the country. And what this indicates is, recall, low transmission rates mean higher mean age of infection and slower accumulation of immunity, which is what we see in the South. And in the North, high transmission, right, means rapid exposure of children early in life and high accumulation of immunity in the North, right? So this empirical pattern seen here is consistent with our interpretation of the transmission rates, which then indicate comparatively low transmissions in the South and comparatively high transmission rates in the North. Um, which again changes our perception of both the risk of current rubella and CRS exposure, as well as the potential responses of these states to vaccination introduction. And in fact, it's in the South where um, where a larger fraction of women of childbearing age, here somewhere between 15 and 20% of women of childbearing age are likely to still be susceptible and to rubella infection and therefore at risk for CRS. Right? Whereas in the North, 95 or more percent of women of childbearing age are already immune to rubella because of exposure to the virus as children, right? So the risk for CRS presently in the absence of vaccination is in fact higher in the South, even though the risk of rubella infection and the transmission rate is higher in the North, right? Um, And so work that was led here by Taishi Nakaze developed then dynamical models to project what the consequences of introduction of rubella vaccination would be. And what this figure here shows on the x-axis is the change in the CRS burden relative to baseline. So the dotted line here is the baseline um, uh, CRS risk, and anything that moves to the left would be a reduction in CRS over a 30-year period following introduction at current vaccination rates, and everything at the right would be an increase in risk in CRS over 30 years. And so what jumps out is that the vast majority of the country, and disproportionately the southern states, if rubella vaccination were introduced at current vaccination rates, would see a reduction in overall CRS burden, so an immediate and direct benefit. And it's only these states that are disproportionately concentrated in the north that would see a potential for an increase in CRS over time. So there's heterogeneity and variation within the country, right? But this set of assumptions here and these results here only assume the introduction of rubella vaccination through the routine program alone. And what we were able to do then was to combine that with the contemporary approaches for measles vaccination in Nigeria, which include both a large wide age range introduction campaign at the point of rubella introduction, which is currently what's being planned and implemented in Nigeria as we speak, as well as continual SIAs in underperforming states over time every several years. So the combination of both this routine vaccination and these supplemental campaigns. And what this work showed was that the combination of those two things absolutely reduced the risk, even in those states that have low current routine vaccination levels. And so, in fact, that we have a large portion of the country and a huge component of the population that would directly benefit from rubella vaccination immediately, and that those parts of the population and those parts of the country that are potentially at risk for this paradox, right, could be easily mitigated using existing strategies that don't actually require additional activities over and above this. And in fact, importantly, if we make even modest assumptions about the improvement of the Nigerian vaccination program over time, don't assume that things will stay constant at current levels, but that the routine vaccination program itself will likely improve, even by only 1 to 2% per year, right? Then that future outcome can be avoided. And it was in the context of that new evidence and this very powerful case study that came that was largely predicated on these observations that came from Nigeria and a comparable set of observations that came from work in collaboration with the Ministry of Health in DR Congo as well. That formed the basis of the argument and the case that was brought to World Health Organization in fall of 2024. And the outcome of that meeting was now a change in the WHO recommended policy to now encourage universal introduction of rubella-containing vaccine. And at that point now, for 13 countries with no current plans, so there were six at that point. Six countries had plans, and 13 had yet to make those plans. And so now WHO recommends universal introduction in all countries, which I think paves the way for dramatic improvements in control and reduction in CRS, and potentially the elimination of rubella virus globally. So we were enormously happy and very excited about that, about the result. But notably, this was a result that really only could have occurred through the combination of empirical data from individual countries that could allow for the development of these sort of powerful stories and case studies that were grounded in empirical data that could be seen and held in hand, mathematical models that helped integrate those things and allow us to project and put quantitative values on things that we can't see, the number of cases avoided, as well as a future that is uncertain but can be based in empirical evidence. As well as, so not just the research side, but also the integration and collaboration of an enormous and enormously diverse and broad set of partners that come from both the public health community here, so the Nigeria CDC and the US CDC, as well as the ministries of health in DR Congo and a number of other countries, as well as policy partners and implementation partners that were able to pull this set of stories together so that they moved beyond just a set of abstract mathematical equations that live on a page, and put them into a sort of meaningful context that can be interpreted, digested, and acted upon by the breadth of policy experts that were necessary to advance a policy change. And so with that, I realize I'm 2 minutes over time, and some of you guys are 2 hours into this because of the late start. And so I am at the end of my presentation, and I want to thank you for your attention through this. And if anybody wants to stay around and ask questions, I would be happy to answer them. Thank you.
Thank you very much, Matt, for that brilliant presentation. So, I don't know, can we have questions or comments from anyone? You can also leave your questions on the chat if you want.
There's a hand up.
Okay, go ahead, please.
Good afternoon, sir. Thank you for the presentation. Please, my question is, you talked about immunity for rubella in the north due to, you talked about the people in the north developing immunity against disease, against the rubella disease. So I want to know that if you have been exposed to measles, the the much I read about it was that it has a permanent immunity after exposure for a period of time. So does that determine why those in the north will be immune to the measles, and then it can affect others in a less predominant area?
Yes. Immunity to infection with either measles or rubella is presumed to be quite long lasting. There's some increasing evidence that that the antibody response, so measures of the amount of antibodies circulating in the body following vaccination decline over time, and so older individuals that were vaccinated as children certainly have lower antibody responses, and which in some sense means lower immunity. With that said, it's not clear whether or not those lower responses are low enough to allow a reinfection. Right. So right now, all we can do is measure the antibody levels, and there has not been strong evidence anywhere in the world of meaningful amounts of infection of older adults decades after their vaccination. There are a handful of documented cases globally, so it remains possible, but it is not. There is no indication at the moment that it occurs at a high enough rate to be sort of of sort of meaningful public health relevance, that it occurs at a high enough rate that it should change. It should be treated as anything other than a rare and random event.
Okay.
That accumulation that accumulation and long-term protection necessarily means, again, that in high burden areas, and again, so the north is higher burden for both measles and rubella, that disproportionately, anybody older than about 5 years old, and certainly older than about 10 years old, is either vaccinated or previously infected, and so of comparatively low risk. And so it's those younger age groups that are the ones that are the more likely target and the more likely beneficiary of vaccination activities. And how that translates into sort of likely policy, both at the clinic level, right? If you see a child with febrile rash and they are older, right? They're 15 years old and they present with febrile rash in clinic, it's unlikely that they have measles or rubella if they're in the north, right? But a 5-year-old or a 3-year-old with febrile rash in the north is far more likely to have measles. That's different, right? Your clinical interpretation of a 13-year-old with febrile rash in the south would be different, and there's a 13-year-old with febrile rash is unlikely to have measles because vaccination rates are comparatively high, but is perhaps perhaps may have rubella, right? So that's how that manifests at the clinical level. And then at the public health and vaccine program design level, that manifests as the marginal benefit, the additional value of vaccinating older children in the north is comparatively small, because most children in the north right now are already immune. Most older children in the north are already immune, right? Whereas in the south, right, the likelihood that a vaccine administered to a 13-year-old in the south is more likely to find itself into a child that is currently susceptible, because the circulating risk and the circulating prevalence is comparatively low. Does that help?
Okay, thank you very much.
Thank you.
So, any other question?
So, Thank you, Matthew, for the wonderful presentation. I don't know if you can hear me.
Yes, I can hear you. Yeah.
Great. So I want to ask, basically, out of the presentation that you made concerning the prevalence of measles and then of rubella again growing to the older population. So until I've known before now that's using the MMR vaccine, the measles, mumps and rubella vaccine. I don't
Hmm.
know. Um, of course, it's very great to hear that from the last 2 or 3 slides that you presented of WHO now considering out of this vaccine, that's a kind of universal coverage now to include perhaps the older population. So I don't know. What do you think might be the effects of such rollout when it comes to the older population, considering perhaps some of the effects of immunity in those other population? How do you think that are there other studies that have been considered for WHO to make those kind of recommendations? So thank you.
So it was a little choppy, the question. So let me say it back and see if I got what you were asking. So you're asking about um, the the effects. So the role. So in Nigeria and most of the remaining countries now, the rollout is switching from measles only vaccine to measles and rubella vaccines. So MMR, as is not what's currently being recommended as part of the national programs for those remaining countries. And the reason for that is because is an economic argument, because the MMR vaccine is comparatively more expensive, and the burden of disease attributable to mumps is comparatively low, and so the cost benefit is at present not felt to be high enough to justify the additional economic cost of MMR compared to MR. MR is what's being proposed for the rollout. But then your question was about what would be effects in the older population? Is that was that the basis of your question? And when you say older population, could you just give me a sense of what ages you mean for older population?
Yeah. So just like the rollout of those the MMR vaccine targets the younger population. So what would be the effects if WHO is considering rolling out this vaccine to the other population? Are there
Got
some
it. Got
studies
it.
that are conducted to actually validate such effects?
Yeah. Yeah. So the recommendation, the current WHO recommendation for rollout. So when you introduce the vaccine, it should be tied to a nationwide wide age range campaign of all children below 14 years of age. And so that in that initial introductory campaign, which would be a short but very heavy supplemental immunization activity, um, for all children up to 14, that is what's perceived as the 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 um, the current absolute numbers of individuals susceptible over 14 is comparatively low, but is probably a meaningful number. And from the figures that I showed, right, that would be that would might likely be the case, say, in some areas of southern Nigeria. Um, but that first introductory campaign is what is meant to provide that additional protection for adolescents that have currently not yet been exposed to rubella because of low transmission. So the wide age range campaign initially addresses some of that concern and risk to older children, so adolescents. Um, and then absolutely the corresponding reduction in overall risk that you get because now there's less rubella circulating, will have the herd immunity benefit, right, of reducing the risk to anybody older than 14 that is not currently immune. And so that's been that phenomenon has been well established and well documented. But you're very right to be concerned that then that those individuals older than 14 are really very much relying on the indirect protection, the herd protection, to mitigate risk of CRS for those pregnancies. And so oftentimes what is recommended is a system of sort of perinatal or specific targeting of women of reproductive age for additional vaccination. And so again, things like when women come in for so even women that have just given birth, right? So their pregnancy that pregnancy is unprotected, but is safe if they've just given birth. But that implies they're already of reproductive age, and they may likely have future pregnancies. And so in that case, in the clinical setting, those women would be recommended for a consultation for vaccination and encouraged to be vaccinated to protect any future pregnancies, right? So again, and this sort of comes down to once again the sort of cost benefit assessment of using these large campaign-based public health interventions to reach those older individuals. More than about if you make that bigger than about or raise the age of eligibility greater than about 14 years, then the activity becomes so heavy and so expensive with diminishing returns that's not the conventional strategy. And so the initial rollout targets those adolescents, right, 10 to 14 years, as the most cost-effective strategy for doing that. And then it's individual health encounters with women of reproductive age and specific targeting of them through those healthcare encounters is what's recommended as the more likely strategy to be effective and the more cost-effective strategy to be effective in those groups. Yep.
Thank you very much.
Yep.
Any other question?
Yes, bro. Thank you. Can you hear me?
Yes.
Okay. Thank you, Professor Ferrari, for the beautiful presentation. So my question is relating to the measles. Also, you mentioned that the result of your findings show that quality reduced due to shifts in older cases. So I want to ask, how do you explain the shift in older cases? Is it that the older children, they were not vaccinated when they were young, or that they were vaccinated but the vaccine wanes and then they became susceptible again at older age? How do you explain the shift? Thank you.
So these are children that were not vaccinated, and so they remain susceptible. But so they're susceptible when they're born usually with maternal immunity. They lose that maternal immunity between about 6 months and 9 months of age, and then they miss their routine visit, and so they remain susceptible from that point until adolescence. But so they're unprotected that entire time, right? But because circulating virus is rare when transmission rate is low, and transmission rate, if vaccination is high, transmission rate is low, and so the circulating virus is less common. And because it's less common, on average, those children that are unvaccinated, right, and unprotected will take longer to encounter the rare thing, right? I have an example. I mean, when I do this in a classroom with students, I have a clapping game that I use to explain this, and so I'm very tempted to do that. But I'm hopefully you pick it. Hopefully you understand this without me having to do the clapping that I do with children, right? But you can see my hands are already moving to that because I'm so used to teaching it that way. So, but again, a rare thing, right? So I mean I'll do it anyway. I'll snap, right? So a common thing, right, is, the snaps are very fast, right? And so the time in between snaps, or the time from birth until exposure, is very short, right? But when something becomes rare, then the snaps are slower, and the amount of time in between them becomes further. And so that's the intuition for when measles is rare, right? The infections are rare and they're happening less commonly. And so the amount of time between them is longer. And so each child has longer to get older before they become exposed, right? And so yeah, so it's the combination of those two things. It's the unvaccinated kids that are manifesting as the older infections, but it's the fact that it's that reduction in the snapping rate, or the reduction in transmission because of lower prevalence, that gives rise to the shift in age. Yeah.
Okay, thank you very much.
Yep.
Yeah, I don't know if there's any other question. Somebody typed on the chats asking that thanks, Prof, for your presentation. Okay, no. Okay, I would like to ask about the SIR model equation presented on the IDT. What does the lambda signify?
Let me come back to, let me make sure that I have it here. Here the lambda indicated here is the birth rate into the system. And so that's, and strictly speaking, boy, I've never, no, nobody's. I haven't even noticed. There's a typo in this. In these in the equations.
Yes, yes,
A
it's the
critically important
SDT.
typo in the equations.
Yeah, it's the
It should
SDT.
be.
And then the next one
Yeah.
is the IDT. Yeah, we know because
Yes.
minus mu s, because of the minus mu x
Yes.
as S class.
Yes. So first of all, thank you for pointing this out. I won't make that mistake in the future. Thank you for pointing out the typo. But anyway, the lambda here, that should be ds dt. And so that lambda is the incoming rate of susceptible individuals, which is in a non-vaccination system, right, is just the birth rate. And here it should be birth rate. It should be lambda times n, for it to be the birth rate. But I oftentimes shorthand it here with just the lambda, because it allows, I can define lambda in multiple different ways. Here I would as stated here, I would define lambda as the birth rate times the total population size n. But then in other versions of this model, we can then discount that birth rate by, say, the vaccination rate, as a simple representation, as one of the sort of simple representations of this. And again, that's I do this stuff with, but the way that I tend to, because I teach so much, because I teach these things so much, that I have a hard time getting to the complicated models without first stepping through all the simple models, to show the progression of how we build that up. But that lambda, I usually then have write as a separate equation, and specifically define it for the setting that I'm interested in, which is either the birth rate times the population rate, or the birth rate times the population rate discounted by the immunity attributable to vaccination, and onwards. And so I can use this representation without the typo to kind of build out various different expansions of the simple model. Yep. But thank you for catching that, and I will fix that for the next time I give this presentation.
Okay. One
Okay,
question from this answer.
Okay,
Hello.
go ahead.
Okay, so okay, 2 in 1. Starting from the equation, I know that all through the talk, you talked about the number of deaths averted through vaccine, though we couldn't get to see the model with the vaccine, so that we'll be able to see and interact with it. That's one. And then, because in this one, I'm not seeing disease-induced death, so I was looking for how the death that was accounted for. That's number one question. Then the second question has to do with the case of the paradox that was discussed. where we have a
Mhm.
situation where the cases rises above the situation of no vaccine. So I was thinking of what could have caused that. Could it be that because I was thinking that if the vaccination program is continuous and everyone is getting children are getting vaccinated as they are coming into the population. So is it that in the model we considered just a set of people that have been vaccinated at a point in time, and then maybe as over time, maybe that's why the cases he was able to rise above the case of no vaccine, because if it's continuous, so I don't know what would have caused that rise above the no vaccine case when you talked about the paradox. So you may want to
Yep.
shed more light
Yep.
on that aspect as well. Thank you, sir.
Yeah. Yeah. So the answer to both of those questions is that so this simple the again I feel like I need to change the slide because I'm embarrassed now by the typo, but but this representation here is non-age specific, so it treats everybody in these categories as the same, right? But an implicit phenomenon that occurs even within the the non-age specific version of the SIR model is the implicit assumption that the corresponding distribution of waiting times until transitions, right? Until in fact moving from the S class to the R class or the I class to the R class, excuse me, the S class to the I class or the I class to the R class, is that the distribution of those times till events is distributed as exponential. So it's what we refer to as exponential waiting times. And the mean of that will shift. And so implicitly, even though age is not represented here, age does manifest in this. And there's been some lovely work on adjustments to that that show that even without explicitly representing age, you can that there are characteristics of that assumption that can be addressed and can lead to errors and biases in the simple version of this, right? So even though age is not represented in a model in this representation on the screen, age is implicit and does affect the things that are happening in here. All of the dynamics that I talked about with respect to the interaction between measles incidence and case fatality and age-specific case fatality, as well as the paradox for rubella, those are both things that arise and require that you explicitly change this to an age-specific model. And the reason that I didn't put it on the screen, I'm happy to share with you the paper so that you can see it directly. The reason I don't put it on the screen is that once you go to the age-specific model, it's very big, and you have to show a screen with lots and lots of equations on it. And I found that's just it's not very engaging, so I don't do it. um, uh, but so first you have to you have to shift the representation to an age specific model, and then you can explicitly account for the absolute number of cases that are occurring in 1-year-olds and 2-year-olds and 3-year-olds and 4-year-olds and 5-year-olds, et cetera. So you take every one of these equations that is represented on the screen now, and you increase you have a new dimensional representation of this that has an age subscript on it, and then you have to have a representation of how you do the aging and demographic process. So you have the process of aging in, mortality out, and age-specific mortality, and all of those things. Um, and so when you do that, so in the measles case, so I can find the slide, right? In the measles case, right, mortality, right? Mortality, strictly speaking, the time scale of mortality for measles is slower than the time scale of recovery. So the death of a child with measles has no meaningful dynamical impact on the SIR model, because disproportionately when a child dies of measles, they are already past the I class. They're already in the recovered class, right? So while technically you might see you could represent that as in this model as an additional disease-specific loss term in the I category. Disproportionately, it's the doing so has really minimal impact, and in fact, strictly speaking, not medically or epidemiologically relevant because what disproportionately children die because of secondary infections after they have already progressed through the I class. And so really it's just it's the representation of mortality. And the reason that I didn't show the equations here is that it is just simply a translation from newly R to mortality, but it doesn't have a dynamic feedback on the transmission dynamics, right? So from that standpoint, it's like a scalar multiplier on incidence, and it doesn't have a feedback term into the transmission dynamics, but it is age specific. And so here, this is what's shown. Uh, these are the results from Alyssa Sparr's paper that show age in years on the x-axis and case fatality ratio on the y-axis. So it's much higher in young children and much lower in older children. And so in the age-specific model, we take the absolute number of cases in each of those various age classes and then multiply it by the rates that are illustrated here. And as that phenomena we just discussed of lower infection causes higher mean age of infection, fewer cases occurring in the young kids and more cases occurring in the older kids, then those numbers then get multiplied by correspondingly smaller numbers as indicated here, right? And that's very much the same phenomenon that's occurring in the case of rubella, where what's being shown here on this axis is not the prevalence or incidence of rubella infection. What's being shown here is the incidence of CRS, right? So CRS is only the manifestation of rubella infection in a specific group, the women in their first trimester of pregnancy. So your intuition is correct that following vaccination, the incidence of rubella infection always goes down and stays down, right? But it's the incidence of CRS that goes down and then comes back up, because what happens is as you go from here to here, the mean age of infection increases, right? And so here, right, you're shortly after the no vaccination setting, and so so here most of the population that is susceptible to rubella is young, and so therefore not manifesting as pregnancies and not manifesting as CRS. But out here, after rubella has been gone for quite some time, then many children that are unvaccinated have made it through adolescence and made it to reproductive age without exposure, and then can manifest as a pregnancy that is then exposed and CRS, right? So the reason for this increase here is because what's being plotted here is CRS. And your intuition again is exactly right, that if we were plotting the incidence of rubella infection, this would go down and stay down.
Okay, thank you.
All right.
So there is a question, one more before we leave, maybe.
Okay.
In the chat, is it that the transmission rates between the susceptible and infectious individual cannot increase beyond? Is it that the transmission rate between the susceptible and infectious individual cannot increase beyond a limit as the total population increases? That's a question from one of the participants.
Mm-hmm. It's an interesting question. Strictly speaking, in nothing that I've presented, there is no hard limit. So the this is oftentimes represented. You're going to make me keep going back to my typo. Um, so um, uh, um, so generally speaking, this term here, right, is a phenomenological representation of the interaction between susceptibles and infecteds. And this term here, the beta term here, is a representation of the functional transmission rate. So it's some combination of the proportion of interactions that are infectious and the probability of infection given that contact. Um, uh, this term is in the formal mathematical terms, that term is only bounded at zero, so it has to be strictly positive. But there's no I'm not where nobody's imposing a formalism that it has to be below something. This other term, right? This is where the nonlinearity occurs, and this does in fact have a, a bounded maximum on it, because necessarily as more of the population becomes infected, then less of the population is susceptible, and as more of the population is susceptible, then less than the whole population is the sum of those two things, or the sum of those two things plus the R category. So they have to trade off of each other. And so this is the thing this is the component of the equation that creates the nonlinearity, and that's what forces the epidemic curve to turn over and begin to decline. So it's really the contact process between susceptibles and infections that is the thing that is constrained and creates the nonlinearity. The transmission rate, in this strict sense, is not bounded, and in theory can be infinitely high. Though it's not what we see in the real world, but from a mathematical perspective, it is unbounded on the high end. Yep.
Okay. Thank you very much.
All right. Well,
Yeah.
thank you all for your attention and the wonderful questions, and I'm sorry that I couldn't be there in person and have to do this remotely, but I hopefully look forward to being able to visit in person one day.
Yeah, that's good. Thank you very much for your time. So
Yeah.
glad to have you here. So
Yep.
so have a good day. Thank you. Yeah.
Yes.
So
Thanks to you all.
all the
Yep.
best.
Yep.
Yeah,
Thanks for your
thank you.
attention.
Cheers. Yeah.
Yep.
Yeah. Bye.
Yep. Bye. Bye.
So thank you, everyone. Have a good afternoon. God bless you. Go and have your lunch.
Thank you so much, Prof. We appreciate you, sir.
Thank you. God bless you. Enjoy your lunch.
And you too, sir.